Now type 1 is undisplaced. Now what do you mean by the term undisplaced? That there is no displacement at the fracture site, as simple as that. Imagine if this is the fracture site, there is no displacement at all. There is a complete fracture, but there is no displacement, no sort of any rotation. The two fragments are aligned as they were before the fractures. Alright, so that is undisplaced. And type 3 obviously is going to be completely displaced fracture. Completely displaced fracture. That means there is no contact in between the two. Complete displacement. How it is going to be completely displaced? For example, if this is the fracture line and this is the distal aspect, so there is a complete displacement. Both of them are no more in contact to each other. So what we are left with is type 2. Type 2 can further be categorized into two categories. Alright, type 2A and type 2B. So the intermediate category, that is type 2, can be categorized into type 2A and type 2B. So what you tend to see in type 2A is that there is a fracture with incomplete displacement. That means displacement could be there, but it is not completely displaced. Some of the fragments are still in contact with each other, or some area of the fragments are still in contact with each other with incomplete displacement, but without rotation. That means there is no rotational displacement. But in type 2B, obviously, there is going to be a fracture with rotation at the fracture site. So this is how Gartland has classified the fractures into three different types. Alright. If supracondylar fracture is undisplaced, it is type 1. If it is completely displaced, it is type 3. If there is rotation with displacement, it is type 2B. If there is no rotation with certain amount of displacement, it is type 2A. So hopefully you have understood. If the examiner is asking anything related to this question, it will be for the first time asked question. And supracondylar fracture is a common topic to be kept in your examination. That is why we had a discussion of the classification systems also. Alright. Now, previous to this classification, this is the classification which we are following because it is also dictating the management protocol for the supracondylar fractures also. You will come to know how when we are going to talk about the treatment. But before that, if we talk about the previous two types of supracondylar fracture, previously the supracondylar fractures were simply classified by the displacement into extension type and flexion type. So simple displacement was responsible for categorizing the fracture. Extension means posterior displacement, while flexion means anterior displacement. And obviously, you are very well aware that 98% of all supracondylar fractures are of posterior type. So extension type are much more common in comparison to the flexion type. Flexion type is just 2% or less than 2% of the supracondylar fracture. So this is a kind of a classification which is just used to describe the two types of supracondylar based upon the displacement. But nowadays, the classification which is being followed is Gartland classification, which is not only responsible for classifying or categorizing the supracondylar fractures, but also is dictating the management protocol. Alright. So having dealt about the displacement as well as classifications also, finally we came to a very important key clinical aspect of this supracondylar fracture, that is three bony point relationship. Now you tell me, we have already talked about this, that three bony point relationship was there in between the medial epicondyle, the lateral epicondyle and the olecranon process. And if we talk about the fracture that is supracondylar fracture, there is no involvement of these structures at all. That means the fracture is happening above the level of supracondylar region. So will it be disturbed or will it be unaltered? That means three bony point relationship is not going to be affected in case of supracondylar fractures, whether it is a fresh fracture or it is a malunited fracture. Alright. So three bony point relationship is maintained in supracondylar fractures of the humerus. You just try to understand that if there is a fracture anywhere in the elbow, for example, if this is the elbow joint, this is the medial epicondyle and this is lateral epicondyle, and here we are having the olecranon process. So if there is a fracture of the medial epicondyle, lateral epicondyle, if there is a fracture which is involving the olecranon process of the ulna, or if there is a fracture which is involving the intercondylar region, alright. So free bony point relationship would be altered in all these fractures except for supracondylar fractures of the humerus, because it is unaffected. All these three structures are not directly affected by the fracture line. Alright, so hopefully you have understood everything related to the supracondylar fracture introduction. Now comes the management protocol or the management part. Now, as far as the treatment is concerned, first, very important thing that you are already aware of, that if the fracture site is displaced, just try to understand, this is the lateral view of the supracondylar region, and most of the time we tend to see the posterior displacement. So this is the distal fragment, this is proximal fragment, which is posteriorly displaced. The name of the artery which is lying right in front of it is the brachial artery, and the possibility of the compression of this brachial artery or the direct injury to this brachial artery is considered to be higher in case of supracondylar fractures of the humerus. So whenever a child comes to you with the supracondylar fracture of the humerus possibly, then first assessment has to be done of a distal neurovascular status. Actually, this is not only for supracondylar. For every fracture, the first assessment, that means management related to the fracture, after having your A, B, C, D done, you have to go for the neurological assessment of that particular limb which is affected. So distal neurovascular status need to be assessed. Alright. So once the neurovascular assessment has been done, now you decide the management. Now, as far as the management is concerned, it is not an issue, because you can now very easily understand that if the fracture is undisplaced, just imagine if the fracture is not displaced at all, then, or if the fracture is slightly displaced also but there is no rotation, or if there is a displacement without rotation, then these are the kind of the fractures which can be managed conservatively. That means reduction, closed reduction, and above elbow slab immobilization. Alright, so this can be managed conservatively. You need not to fix the fractures because there is no rotational abnormality. You just have to reduce it and put it inside the slab for a period of 3 to 4 weeks. But in case if there is a rotation or there is type 3 fractures, as we have talked about, where there is a complete displacement, then you can go for closed. That means if just by closed maneuver you are able to fix them or you are able to reduce them. Otherwise, if you fail to reduce them, then go for open reduction and internal fixation. Now that internal fixation is done by the placement of K wires. Alright, so open reduction and internal fixation using the K wires is the management protocol for supracondylar fractures of the humerus. Now, if you look at this image, this is what we have already done. Like, this is the supracondylar fracture, this is the AP view, this is not exactly lateral, means the child is not allowing you to put it into a true lateral view. But you have decided that there is a complete displacement at the fracture site, as you can very clearly see, complete displacement, this one region and this one region. And after reducing it, you have to put it, you have to reduce it after reduction is achieved. You have to fix it by the placement of K wires, which can be placed from the lateral also, means placement of the 2 K wires laterally also, or you can go for the cross pinning across the fracture. Alright, and this is how the reduction is achieved. So this is the management protocol. Now, as I told you that closed or open, that don't try, if it is not getting closed by the maneuver that you have applied, then you have to open the fracture site, reduce it under the influence of the instruments, and then directly you have to put the K-wire fixation for them. So that is a management protocol. So as you can very clearly realize that this management protocol is based on the classification system. Like, as I told you, it was dictating, the classification was dictating the management protocol. Like type 1, what is the management? It is closed reduction or without reduction also, just by above elbow slab immobilization. Type 2A, you can go for reduction and immobilization. But type 2B, if there is rotational abnormality, fix it by the placement of K wires. And once it is completely displaced, again you have to go for the fixation. Alright. So this is how Gartland is responsible for the management also. Next comes the complications. Now, every time you tend to see a question out of supracondylar fractures today, is asked out of these complications more commonly. So the first complication that is important for you at the time of the fracture assessment are the immediate complications. So as we have already discussed that the immediate complication could be injury to the artery, that means arterial injury, and that artery which is likely to get injured is the brachial artery. Alright, and the second one is the nerve injury. The most common nerve which is likely to get injured with this supracondylar fracture of the humerus due to the fracture, not due to the management of the fractures, is the anterior interosseous nerve. And all of you are aware that anterior interosseous nerve is a branch of median nerve. Alright, so anterior interosseous nerve is the most common nerve which is affected because of supracondylar fractures of the humerus. These are immediate complications. Next, the early complication. You know, when we have talked about the complications of the fractures, I told you that supracondylar fracture very commonly is associated, if neglected, is associated with compartment syndrome. So one of the early complication is compartment syndrome. And finally, the late complications. Now, as far as the late complications are concerned, now we have already talked about, and we have already talked about when we were talking about the complications, like if the fracture is happening at the corticocancellous region, where there is a porosity, increased porosity of the bone, where there is increased vascularity of the bone, then any complication related to the union you have to decide, then will you choose malunion or non-union as a common complication. So, malunion is a commoner complication related to this fracture. So, it is a late complication. If it is not reduced properly, if it is not fixed, if it was neglected, then the fracture will unite, but it will lead to an improper union, that is malunion. Now, this progressive malunion will result in cubitus varus deformity. Now, this also we have discussed, you know, when we were talking about the two possible deviations from the normal angle or the normal carrying angle of the elbow joint or the mediolateral deviations. One was valgus, other one is varus. Now, imagine if this is the trunk of the individual, alright, this is the arm and this is the forearm, and the apex is pointing away from the midline of the body. So, it would be called as varus deformity. So, in case of supracondylar fractures of the humerus, it will, if it malunites, then it will lead to cubitus varus, alright, not the valgus, where the apex is pointing away from the midline of the body, alright. Now, this cubitus varus is also known as gun-stock deformity, or the cubitus varus deformity is also known by the name of gun-stock deformity. Why gun-stock deformity? Just try to have an evaluation. Now, this is also cubitus varus, but here the limb is kept in abduction. Alright, the limb is kept in abduction, or there is a demonstration of this varus deformity by keeping the limb abducted. Alright, and it appears like a stock of the gun. So, this thing appears like the stock of the gun, and this is the reason why it is called as gun-stock deformity. Supracondylar fractures of the humerus, related complication will result in this deformity. Alright, so hopefully you have understood everything related to the immediate complication, early complication, and one of the late complication, that is malunion leading to varus deformity, leading to gun-stock. This is also called by the name of gun-stock. Another very common complication associated with this, late complication associated with the management of supracondylar fractures of the humerus, is myositis ossificans. You know, we have already talked about this myositis ossificans, and I told you that it is iatrogenic. There is a history of massage. Now, just try to understand or just try to relate that how a supracondylar fracture, if it is not managed adequately or properly, will result in myositis ossificans. You see, majority of the time, these children who are having supracondylar fractures are subjected to or are projected to the local practitioner or a quack. Now, what they do is they friction the arm. That means there is a history of massage, and then they apply a tight splint. Now, if there is a persistent frictional injury of the muscles which are exposed to the bony fragment, it will result in the formation of the granulation bed